that's an example, or patients that require assistance in their care. And finally, where the cause of death is known, but an investigation is required. So an example of this might be patients who have been admitted for some surgery. They've had a mechanical fall post-operatively that resulted in a complication or a death as in relation to that fall. So in conjunction with reporting cases to the coroner, some deaths can be reported to the police. This may be done by the healthcare agency, it may be done by a healthcare individual or by the family. So if the police are involved, they will want to interview the clinical staff that were involved directly in the care of the patient as soon as possible. So just as a reminder, you're not under any obligation to answer those police questions without legal representation. So it is advised to seek some representation either through your organisation or your union or privately prior to answering those questions. Any lines or device that may have contributed to the patient's death must be left in place until the police or the coroner have reported the approval of their removal. If the lines haven't contributed to the death, then it's fine for those to be removed so that the family can come in and visit and say goodbye to the relative. So internally, we will often do investigations such as the root cause analysis or RCA or a HEAPS investigation. So typically these will be completed before a coronial inquest or investigation, and the findings of an RCA or a HEAPS, particularly when we've put strategies in place to improve care, are looked on quite favourably by the coroner in their findings and investigations. All right, so the case that we'll be looking at today, it's the non-inquest findings from the 8th of May in 2020. This can be found, and we'll post a link later on in the presentation. So this is into the death of our patient, who we'll refer to today as FD or Mrs. D. She was a 68-year-old lady who died in 2018. So our patient had a 10-year history of oculopharyngeal muscular dystrophy, and this led to swallowing difficulties that required her to have a PEG tube placed for feeding purposes. All right, so we'll just look at the timeline of events now. So Mrs. D presented to a rural hospital on the 15th of February with increasing dysphagia and bilateral pneumonia. So aspiration pneumonia is what was suspected. Over the next 4 days, she was seen by a range of specialists. Her clinical condition had deteriorated to the point that the tests that they were wanting to do weren't able to be done due to the risk of aspiration. So she was referred to the tertiary regional hospital for further investigations, and she was commenced on nasogastric feeding at that time and booked for an insertion of a PEG tube. So Mrs. D was transferred back to the care of the rural hospital for that pre-operative management until her surgery, which was booked for the end of the month. So the insertion of the PEG went ahead on the 28th of February at the regional hospital with no reported complications, either intraoperatively or immediately post-operatively. So a thorough discharge plan was provided to Mrs. D's daughter, who was providing post-operatively care for her. This discharge planning included information on how to care for the PEG, including the intermittent feeding, and Mrs. D's daughter was assessed as competent in both providing the care on the PEG tube and the feeding through the PEG tube. So as per the discharge instructions, as soon as Mrs. D's daughter identified concerns in her condition, she took her straight to the ED of the local rural hospital. And this is where we'll start the story today. So on presentation at the rural hospital, the senior medical officer examined Mrs. D and on examination noted that she did appear quite deconditioned. Her chest was clear and her abdomen was soft, but there was some epigastric tenderness around the PEG site. Her observations were as charted, and of note was an increase in her respiratory rate and a drop in her oxygen saturation level, and she had quite a high temperature at this stage of 39.1. So some bloods were ordered on Mrs. D, as was a MSU and a chest X-ray, and they were to be done the following morning. Venous blood gas was collected, and this showed a lactate level of 2.98. All right, so we'll just start our first poll. Just get back to my other screen. So I'll just launch this first poll for you. All right, so the first poll, the most significant piece of information provided during the initial ED assessment was what? So if you just click on your answers, A, B, C, or D. All right, we'll have a couple of more minutes and then I'll close that poll box. I think most of you have answered now. So a few more minutes and a few more seconds, not minutes, and I'll end the polling. All right, so I'll just share those results there for you so you can have a look. So a lot of you have identified as the elevation, the temperature as being most concerned. So temperature of 39.1 and a little bit of even spread between respiratory rate and the lactate level. So that's good to see some of you identifying the lactate. And then the epigastric tenderness being of concern. All right, so at this stage, there is no one finding that is most concerned. It's actually the contribution of or combination of all the variables that's most significant. Now, normally I would take this opportunity to really drill home that important message of recording at a respiratory rate. So we know that it's our least performed observation, and it's frequently a guesstimate rather than an accurate 60-second count of the patient's breathing. It's really hard for us to differentiate between a respiratory rate of 20 and a respiratory rate of 22. And we know that 20 is within normal parameters, but 22 is reason to escalate. It's an area of concern. So the fact that her respiratory rate is elevated now is of concern, particularly with that drop in her oxygen level. But what about the epigastric tenderness and the lactate and the temperature? How do they all fit into the equation? So let's have a look. So we'll start the next interactive poll. So given the presenting information, which of the following are you most concerned about? So what do you think those variables are showing with Mrs. D at this stage? So given her preoperative assessment and the events that have occurred with no complications intraoperatively, no complications in that immediate postoperative experience, putting all of that piece of information together, what do you think is going on with her? All right, and we'll just wait a few more minutes. About half of you have answered the poll.
A few more seconds, I think you mean, Susie?
I do. I like to say minutes when I mean seconds. All right, so I'm just going to end the poll results there. And I'll share those results with you. So pretty much what I would expect to see. So we've got quite a few of you that are concerned about abdominal sepsis from a malpositioned PEG tube. And quite a few of you identified that perhaps the concern is exacerbation of that preoperative pneumonia, and certainly is a risk factor given Mrs. D's history. Right. So, Abby, if you can just pop in the link to the bumper at this stage, so the first link, please. So Mrs. D was admitted for recurrence of aspiration pneumonia, query post-operative complication. There was no documentation at this stage in relation to the PEG bumper position. So the link that is appearing there in your chat box just talks a little bit about the complications of buried bumper position. So the bumper is essentially the anchoring point of the PEG tube. And if that becomes malpositioned, then it can lead to complications. So bloods were collected on Mrs. D, but there was no blood cultures ordered at this stage. The chest X-ray and MSU were ordered for the following morning, and she was admitted for pulse oximetry monitoring. PR medication was documented, and she was just for standard observations at this stage. So on admission, she was administered some PR paracetamol and the endomethacin. Her temperature and respiratory rate remained elevated overnight. They had a lot of difficulty obtaining IV access. So the antibiotics that had been prescribed to her were then administered via the PEG tube rather than IV. These antibiotics were commenced after her daughter provided the equipment to look after the PEG tube and to use to access. So her first dose of Augmentin, which was via the PEG, was administered around 6 hours after she presented to the hospital. Routine bloods were collected without any blood cultures, and these bloods were held and then sent to the lab in the morning. It's unclear from the coroner's documentation whether or not these results were reviewed when they were received. So the following day, Mrs. D continued to receive paracetamol regularly, so 4th hourly by the PEG. She had her intermittent PEG feeds recommenced in the morning, and these were done in accordance to the routine feeding regime from the regional tertiary hospital. Unfortunately, the dietitian wasn't available to review her that day, but the speech pathologist did come in and review her and commenced her on a small amount of pureed diet and regular fluids. So she had 4 lots of 5 ml doses of oral fluids. The PEG feeds were commenced at 1200, so midday. So I thought it would be timely, given that Mrs. D received a lot of paracetamol, just to talk about the role of paracetamol. So we do frequently administer paracetamol, particularly when we see an elevated temperature, and certainly a lot of you were concerned about that elevated temperature that Mrs. D had of 39.1. So paracetamol may not be the magic bullet that we're after. It will often mask symptoms that would otherwise help us to identify deterioration from sepsis earlier. And we need to be aware of that if we are administering paracetamol, that it can sometimes mask symptoms that would lead to earlier escalation. There is some research that suggests the reduction in fever helps to reduce the body's inflammatory response to infection. But in almost all cases, it is suggested that paracetamol actually shouldn't be administered unless it is specifically relieving significant distress that will be contributing to deterioration or oxygen consumption. So unless the patient has been actively treated and diagnosed for sepsis or is in the ICU, we should be really cautious about administering paracetamol. This is particularly true, we should have particular caution around the administration of IV paracetamol, as this contains mannitol, and that's a known vasodilator, so it can actually exacerbate the hypotension that we see in septic patients. So that's just some background information about should or should we not be giving paracetamol to our septic patients. So we'll move on now to the timeline and looking at the signs of sepsis. So the blood results that came back showed an elevated white cell count of 18.6 and neutrophil count of 16.3. Mrs. D had raised inflammatory markers, so a CRP at this stage was 36. Her chest X-ray did show some atelectic changes, but there was improvement from her previous preoperative chest X-ray. So this is an indication that the risk or the sort of fear of aspiration pneumonia probably wasn't the cause of her deterioration at this point. So on the track and trigger observations, her BP was checked and recorded at 80/50 initially. She was also documented as having some pain on immobilization. So with the blood pressure of 80/50, the nurse took that blood pressure with the automatic machine, rechecked it manually. So there was 3 rechecks that was done, and on the second manual redo, the recording of the BP was 92/54. So this was documented on her chart, And the doctor was contacted, but they didn't have any further observations. So we'll go on to our next poll now. Let's open that back up. All right, so when checking a blood pressure, the best recording should be used. So if you can just put in your answers there for what you think is correct. A lot of you have gone in straight away. All right, so most of you have voted now. I'll close that poll up. And I'll just share those results. So most of you have indicated that no, we should be looking for some more adverse findings. So when we do get a low blood pressure, that is often going to be the most accurate. So rechecking it might make us feel better about the situation, but a low blood pressure should always be assessed further for complications. All right, so just a reminder about blood pressure. So a systolic blood pressure of less than 100 is our usual flag for deterioration. However, for patients with a normally higher blood pressure, we need to be considering often an elevated blood pressure as their sign of deterioration. So a fall in blood pressure of 40 or more should be considered as a sign of hypotension in these patients. Manual blood pressure should definitely be checked when we have got patients either with an irregular pulse or where we've got concerns and particularly low blood pressure. Patients won't always have corresponding changes in observations, so any abnormal observation does warrant further assessment. So for Mrs. D with her blood pressure, her usual or target blood pressure was actually documented as 110. And so when they did the second blood pressure check on her scoring the 90s, she only scored a 1, whereas in reality, she had a history of hypertension. So that blood pressure of 80 and even in the 90s should have escalated to an emergency call. So this was a missed situation for Mrs. D at this point. All right, so we'll move on to our next poll. So Mrs. D is hypotensive. She's complaining of pain and has an elevated white cell count. Her respiratory rate, heart rate, and oxygen saturations are all within normal limits. Do you think that Mrs. D has got sepsis? All right, we've got answers coming in thick and fast. So a few more seconds and I'll close those polls. All right, so most of you have voted now. And as you can see, most of you agree that Mrs. D does in fact have sepsis. Few not sure, don't think she does, or aren't prepared to diagnose as a nurse. So just as a reminder at this point that it's good for us as nursing staff to have an understanding or a suspicion about what's going on with our patients. It certainly helps us when we're trying to escalate to the doctors if we can put that diagnosis in place about what we think, so that when we're communicating, it's nice and clear for the doctors what we're worried about. All right, so what to look for sepsis? So these are our important criteria that we can look at so that we can identify when our patients have got a simple infection, when they've got sepsis, or when they've got septic shock. So Abby, if you can put the second link in the chat box now, this just is some incidence on the incidence rates of sepsis that you can look at later. So signs of infection will include elevations or a drop in temperature, so temperatures greater than 38 or temperatures less than 36. Elevations in our white cell count or microbiology that actually comes back with positive blood cultures, or it might be positive screens, whether it's a MSU or a swab that's been taken from a wound or some other site. The presence of invasive lines or procedures. So these are our patients that we should be flagging as at risk for infection. So we might not see anything that indicates infection, but it certainly is a suspicion of sepsis if they've got those other criteria. So for sepsis, we're looking at changes in their heart rate, so an elevated heart rate or respiratory rate greater than 22, drop in oxygen saturations less than 95%, and a lactate level elevated greater than 2. So 2 is our normal ranges. For signs of shock, we're looking for hypotension, a lactate level greater than 4, and capillary refill greater than 3, or a low urine output. So they're the things to look out for if you're worried about sepsis in your patients. So we'll have a quick review of pathophysiology. Like everything pathophysiology, it is complicated processes, and often I allocated a whole hour to talk through pathophysiology. So this is pathophysiology sort of speed dating style. So we know that sepsis is essentially a disorder of coagulation. So damage to the endothelium plus the presence of a microorganism results in the activation of both the intrinsic and the extrinsic coagulation pathways. So this will lead to formation of platelets and clots forming on the damaged endothelium. We also start to see a leak in the permeability of our endothelium. So we'll actually start to see some loss of fluids from that damage to the endothelium membrane. So fluid will start to leak out of the interstitial spaces, from the intravascular space and into the interstitial space. So this is why we start to see hypovolemia in our septic patients. So that activation of that inflammatory response activates our monocytes. So we release our interleukins and our cytokines, and the same thing happens along the endothelium. So the next thing that happens as a result of that inflammatory response and the activation of coagulation is we'll start to see a thrombotic response to infection. So our thrombin is then activates our fibrin, which forms a fibrin sort of mesh over our platelets that helps to stabilize the clot so the endothelium can start to repair itself. And this is our normal coagulation cascade. The damaged endothelium, as well as releasing sort of platelets at that site, also reduces the rolling effect of our neutrophils. And this actually has a reduced ability to fight infection because the neutrophils can't roll adequately. So we're now seeing that increase in coagulation as a result of the infection. And finally, our normal process of fibrinolysis. So normally once the endothelium has repaired, fibrinolysis would start to happen. So TPA would get released and that will start to break down that clot. But in sepsis, we don't see that. So fibrinolysis won't occur because we're now producing some counter products called PI1 and TAFI. So PI1 stands for plasminogen activator inhibitor, and this actually stops TPA from working. And TAFI is thrombin activated fibrinolytic inhibitor. So essentially that puts the handcuffs on fibrinolysis. So they're activated by that inflammatory response. And our septic patients will now start to see an increase in the amount of coagulation, but a decrease in the amount of fibrinolysis or clot busting. So as a result, platelets can be starting to be consumed. So we'll have a low platelet count. This will lead to an increased risk in bleeding of these patients. And we know that sepsis is one of our causes of DIC, which stands for disseminated intravascular coagulopathy. So that process where we have lots of clots forming, but also bleeding. So ultimately what we now see is clots along our vasculature. So our blood flow can't reach our end organs. We have a decrease in perfusion in our end organs, and we'll often start to see some organ dysfunction. In addition, those sort of clots that are forming there can actually be quite unstable and break away with blood flow. So we'll start to see some microemboli. And typically what we're starting to see now in our patients is those areas of necrosis. So often sort of fingertips and tips of noses and ears will get that necrotic sort of look about it. And this is why a lot of our septic patients go on and actually require amputation of limbs. So it's from those microemboli that are causing problems. So our responsibility is to try to make sure that we're actually identifying sepsis early to try to manage this problem so that we're not seeing the blood clotting disorder occurring, so that coagulation cascade. So Abby, if you can just add in link 3 for me now, please. So our signs of sepsis. So previously we had a combination of criteria and a combination of definitions when we talked about sepsis. And unfortunately, this did contribute to some of the confusion around sepsis and delays in recognition. So we used to talk in terms of SIRS, or systemic inflammatory response syndrome. So this was our original tool to identify sepsis, but we know we see SIRS in a lot of other conditions, not just sepsis. So SIRS include elevations in heart rate, respiratory rate, white cell count, and our high and low temperatures. And a patient with known or suspected infection and 2 or more SIRS criteria were then identified as having sepsis. We then had that continuum where we had sepsis, septic shock, severe sepsis and septic shock. We've now moved on to something a little bit simpler called our Q-SOFA score, and this is built on the sequential organ failure assessment, a tool that we use in ICU for predicting mortality rate. We know patients with a SOFA score of 2 or more actually have a greater mortality rate than patients with an ST elevation myocardial infarction. So it's really quite a significant tool for identifying mortality. Our Q-SOFA, though, is designed to be used at the bedside outside of the ICU environment. So it helps us to quickly identify septic patients that are at risk of deterioration or who have a high mortality rate. So our Q-SOFA score consists of patients who have got a respiratory rate greater than 2, are hypotensive, so a systolic blood pressure of less than 100 or more than 40 drop from their normal blood pressure, and patients with an altered level of consciousness, so Glasgow Coma score of less than 15. Lactate is often used as a biomarker for metabolic stress, and it's often talked about as a biomarker for sepsis. So in patients with an infection, if they've got a lactate level greater than 2, this does suggest sepsis and we should be treating them as such. A lactate greater than 4 with hypotension does suggest septic shock. So these patients should be having fluid resuscitation, and if their lactate level stays high or they remain hypotensive and tachycardic, we should be considering a noradrenaline infusion, so some vasopressor therapy at this stage. So it's really important at this point with our lactate that we don't use it as the sole marker for sepsis. So we do need to just be aware that lactate can indicate other problems besides sepsis. So we do want to make sure that we're linking that elevated lactate level with an infection. All right, so looking now with our case study and how she was escalated at this point. So between the 1st and the 2nd of March, Mrs. D did continue to display some symptoms such as abdominal pain. She had some drops in her oxygen levels, and her elevated CRP when it was rechecked had now increased up to 346. Her PEG site did remain intact throughout this time. There was no local inflammation and her feeds continued. So on the 2nd of March at 4 p.m, she suffered an acute deterioration. So 30 minutes following a PEG feed, Mrs. D started to cough and vomit. She was feeling generally unwell at this stage. Her PEG was now leaking extensively. On examination, her abdomen was distended with generalized tenderness. Her observations, though, were all within normal limits. So at this point, because she was quite unwell, there was concerns with her PEG, a CT abdomen was ordered and the regional hospital was contacted for surgical referral. All right, so we'll just move on to the next poll. So you've been asked to provide a clinical handover to the surgical registrar using the SBAR format. So after you've introduced yourself and you've identified the patient that you're talking about, what would you say next in that handover? So choose from the options. And I'll just, Ken, is there anything that's come up in the chat box or the Q&As at this time that I need to address?
Towards the end, I thought a couple of people have asked about the evidence for paracetamol and not using it in septic patients.
Sure. Yep, we can talk about that.
And then there was a couple of other questions that I thought I could comment on as well, but nothing of a major trend through there.
Okay, great. Thanks. All right, so a few more seconds for you to answer this one. All right, so I'll just end that poll now and share the results. Great, and look, the majority of you have chosen the best option there. So it's really important when we're providing handover that we're quite succinct with what the information is that we're talking about. So we need to identify that we're worried about abdominal sepsis, using language like I'm worried, I'm concerned. That gets the attention of the team that we're talking about. Giving them the specific information. So the fact that Mrs. D's PEG is leaking, that she started vomiting after her last feed. So that gives them the data that she needs. And then giving them a time frame. So what is our expectation? We really need her to be reviewed at this stage. So that's some good responses there. All right, so Mrs. D at this stage was ordered to have a CT. So she went off and had a CT of her abdomen and a pegogram. So this was performed fairly quickly after that initial deterioration. During the scans, the nurse stated that they were quite concerned about Mrs. D's clinical status and her instability during the scan. But there was no documentation of this, and there was no documentation around whether the nurse actually escalated or communicated their concerns to the doctors. So this is a really timely reminder that we should always be documenting when we have got concerns or when there's a variance in our patient, and also to document when we have escalated and communicated those concerns. So a verbal report on the scans was provided to the senior medical officer, and they contacted the regional surgical team. But at this stage, they actually required or requested a copy of the written report before they would accept the transfer of Mrs. D back into their care. The written report was available around 7 p.m. and the surgical team was then contacted, but unfortunately at this time, they were scrubbed into another emergency case and unable to receive the call. So the oncoming senior medical officer at the rural hospital then contacted the ED of the regional hospital with their concerns, and the ED accepted immediate transfer of Mrs. D. So that they started to then arrange that. Lost my mouse. All right, so we'll open up the next poll. So in addition to the IV antibiotics that were prescribed, which of the following do you think Mrs. D needs as a priority? So answer A, B, C or D there. All right, a couple more seconds and I'll close the polls off. All right, so I'll just end the polls there and share those results. So the majority of you have identified the requirement to administer some IV fluid, so 20 to 30 mils of sodium chloride fluid resuscitation. Some of you have talked about giving some oxygen as well, and a few of you have sort of said analgesia and warm blanket and reassurance. So obviously, yes, we do want to give some fluid resus and oxygen. These are important things for stabilisation, but we should never overlook the importance of making our patients comfortable. So that reassurance, talking to our patients, giving analgesia, all of those things will help to decrease anxiety. And this in turn will actually help to stabilise our patients because it can decrease some of that oxygen consumption. So while it can get tricky because we're trying to prioritise things, we should never overlook those basic things that can help our patients out. So when we talk management of sepsis, the Sepsis 6, which was first published in the UK from the UK Sepsis Trust. So this is now widely used in our sepsis pathways that we have got access to. So it focuses on 3 treatments and 3 monitoring requirements for our patients with sepsis. So Abby, if you can put up the 4th and 5th link there around our surviving sepsis guidelines and just some additional information around fluid resuscitation and vasopressor recommendations. So the Sepsis 6, our priorities, we need to make sure that our patients are stable first. So yes, we do need to give some oxygen therapy to keep the saturations greater than 94%. So remember with our septic patients that they will have a higher oxygen requirement. Their metabolism has increased. They've often switched over to anaerobic metabolism, and so they'll be consuming more oxygen. So we do need to supply them with some oxygen. We do need to give some fluid resuscitation. So the current recommendations is 20 to 30 mils per kilo of a crystalloid. Normal saline is the preferred solution, but there is some debate around which solution we should be using. So normal saline, Hartmann's, there's some talk for plasmolite as well, but we do know that we should avoid colloid in these patients. So colloids can increase that inflammatory response. It's important that we have source control. So we want to take some blood cultures and do any other sort of septic screen. So for Mrs. D, that would include, if we're able to get some of that fluid that is leaking from her PEG tube, but certainly a swab around that site just to identify if there's a pathogen there in that fluid that is leaking out. So our blood cultures and source control, we should start doing before we administer IV antibiotics, but IV antibiotics should be administered as soon as possible. So within 60 minutes of the identification of sepsis is the recommendation. From a measuring point of view, we want to measure to see if our fluid resuscitation is effective. We want to be measuring that to our endpoints. So we need to be measuring both our lactate and our urine output in addition to our normal observations. So most states around Australia have got some sepsis pathways, and this is an example of the adult sepsis pathway that we use here in Queensland. The Australian Sepsis Network have got a range of educational materials that you can access. And Abby, if you want to put up link 6 in the chat box, that will take you to the Australian network that you can access later. So in Queensland, we've got the fairly newly developed adult and paediatric septic pathways, and that's an example there. So you can access these anywhere in Australia with permission. So you just contact that email address to access that. And this tool was actually not in place in the hospitals at the time, but they have put that in place as a result of their RCA. And this is where we're starting to see the benefits of doing sort of both RCAs or HEAPs. We start to put in place protocols that will help reduce the risk for our patients. All right, so we'll look at our next poll now. I'll just launch that. So I'll just give you a bit of background information as well while we've got that poll up. So you've volunteered to accompany Mrs. D in the ambulance to the regional hospital. You haven't done an ambulance transfer before, but has you have attended the training on inter-hospital transfer, and you've done your orientation to the ambulance. So the ward nurses provided you with the following handover. An acute resuscitation plan has been put in place and discussed with Mrs. D, and she's for full resuscitation. Her current observations: respiratory rate is 30, oxygen saturations are 88%, her heart rate is 112, she's got a Glasgow Coma scale of 15 and a normal level of consciousness. Her PEG has become dislodged, resulting in peritonitis and sepsis. In addition, you do overhear the nurse telling the paramedic that Mrs. D is quite ill and she may deteriorate during transport or during surgery once she reaches the regional hospital. Mrs. D's daughter has requested to accompany Mrs. D in the ambulance, and this has been granted. So if you want to now answer that question on the poll, so which of the statements do you agree with, A, B, C, or D? I'll just give you some time to answer that. We can see that it's a little bit harder to make decisions around this because we've now got a lot going on with our patient. She's definitely showing some real signs of concern and deterioration, and knowing that we've got a road journey ahead of us. And I know not all of you work in those rural and regional centres, but quite different than working in a metropolitan centre where our transfers are usually from one ward to the other and take about 5 minutes to do. A lot of our rural transfers can take certainly several minutes to hours in some instances. So I'll just end the polling there now. Most of you have answered. And I'll share those results. So most of you have said that she's really too unstable to transfer by the road, and retrieval services should be contacted for aerial transfer. And some of you have identified that Mrs. D can safely be transferred by road with 2 paramedics and a critical care nurse and a doctor or a doctor. So we've got some good support there. But a daughter should follow in a private vehicle. And it's certainly a tough decision to make. So the decision to transfer was made with a sense of urgency. So Mrs. Daughter was allowed to accompany her mum in the ambulance. There was one paramedic who was the driver and the nurse who was providing care in the back of the ambulance along with Mrs. D. At that stage, because the paramedic was a little bit concerned about the verbal handover that they had received, they did notify and request for some more backup and just to alert them. The decision was made to transfer via road because aerial retrieval just wasn't possible. So it was actually quicker to make the transfer via road at this stage. Unfortunately, en route to the regional hospital, Mrs. D did deteriorate, and the decision was made at that point to divert to another rural centre. So initially she had quite an elevated blood pressure, but the nurse was uncertain how accurate it was because of the equipment that she was using. So on rechecking, her blood pressure was starting to come down. She was becoming more acutely hypoxic. Oxygen was increased at that stage. So she was they were rerouted to another rural hospital. And at that rural hospital, there wasn't the medical coverage. So there was one doctor at that rural hospital who actually couldn't leave that site. So they did make contact with retrieval services. But again, the retrieval services was going to take several hours to get there via helicopter. So the decision was made to continue via the road transfer. At that stage, retrieval services recommended metaraminol infusion to be commenced during that transfer to help to keep Mrs. D's blood pressure stabilised enough. So within a few kilometres of leaving that second rural hospital, Mrs. D actually arrested in the back of the ambulance. So they pulled over, CPR was commenced by the nurse and by Mrs. D's daughter, and the decision was then made to return back to that second rural hospital. So they turned around and went back to the rural hospital. So despite all resuscitative efforts at this stage, unfortunately, Mrs. D was unable to be revived. And Abby, if you can just put up the link to the Safe Transport Guidelines, so the final link there, please. So what we're starting to see on investigation now is what we sometimes refer to as retrospective bias. And certainly in that previous quiz, the poll, a lot of you said that she was really too unstable to transfer in the first place. And part of that decision making was, we know what has happened to Mrs. D. So it makes it us easier to know that she's going to deteriorate, and perhaps it's better to stay where we are. So when there are time pressures and resources that are restricted that sort of influence our decisions, we do make decisions based on our best intentions, what we think is going to be the best for the patient. So looking retrospectively, it is easier to see what would have been possibly a safer solution. So this is what we refer to as retrospective bias. And it can lead in investigations to blame put on clinicians during an investigation, rather than an open analysis of all potential problems. And it's important that we do look at all of the potential problems that has led to an incident.
Just on that previous slide, Susie, a few people have pointed out there was a typo. Should have been hypotension en route, not hypertension.
Oh, she actually suffered from hypertension initially. So,
okay.
So yeah, her blood pressure was actually 210 initially, but they were contributing that to the piece of equipment, and on rechecking, she became hypotensive.
Okay, why she needed the meteramol infusion?
Yeah. So by the time she made it to the rural hospital, her blood pressure was in the low 80s, whereas in the back of the ambulance, it was recorded as 210.
Thanks for clarifying that.
That's okay. So despite the best intentions of all the clinicians directly and indirectly involved in the care of Mrs. D, by the time the initial transfer was able to take place, she was now in a dire situation. And this is where we're seeing all of the things lining up in that Swiss cheese model that we look at when we're talking about patient harm. So the coronial report, which if you can add link 8, Abby, so this is a copy of the coroner's investigation if you're wanting to read that later. So it identified that there was actually a missed opportunity back on the 29th of February. So when Mrs. D first presented to the rural hospital, this is where we missed that opportunity. There wasn't the identification at that point of abdominal sepsis. So the treatment that was put in place then was for query aspiration pneumonia. So the initiation of the sepsis management via the sepsis pathway was most likely what contributed to Mrs. D's death. So when we review this case, we can see how the holes in the Swiss cheese are lining up. So from the pre-surgical complications of her chronic illness and poor nutrition, and really that red herring of the aspiration pneumonia preoperatively influencing her post-operative management. The lack of familiarity by the rural team. I don't know how many of you out there have cared for patients with PEG tubes, but they're not the easiest things to care for. And if you haven't cared for them before, there's a lot of additional information that you need to know to understand how they work and operate. The failure to recognise those early signs of sepsis and the lack of utilisation of the sepsis clinical pathway. If you remember back on admission, Mrs. D had an elevated lactate of 2.98. There was no fluid resuscitation commenced at that stage. She was hypotensive, but this wasn't flagged because of the incorrect scoring on the observation chart. No blood cultures were done, so she didn't have a full septic screen performed. While she had some blood tests done, they didn't do a blood culture, and that delay in the initial antibiotics. So the IV antibiotics weren't initially administered because of poor IV access. She had the antibiotics via the PEG tube, but that was 6 hours after admission. So throughout the case, the escalation wasn't always effective. So we didn't have prompt sort of escalation to the surgical referral team. So some communication breakdown between the treating teams and the hospitals meant that we didn't have the right resources sort of mobilised at the time that we wanted. So there was a lot of pressure to act without the adequate sort of skill and resources available at the time. So one of the things that we should always be thinking about is there more to see? So when you look at this picture, what do you see? So some of you might see an elderly man or an elderly lady looking at each other. Some of you might see the yellow vase in the background. But who of you can see the Mexican man who's playing his guitar, or the Mexican lady who's listening along with the curtain moving in the breeze? And just in case some of you can't see that, I'll point those things out. So we can see here, this is a big picture, if you can see where my mouse is moving, of the lady, the big picture of the man. Hopefully you can all see that. This is the yellow vase in the background. But if you look more closely at the faces, you can see here the Mexican man playing his guitar. There's another lady in the background, and then the Mexican lady, and this is the curtain moving in the breeze. So we should always be asking ourselves clinically, are you seeing what everybody else is seeing? Is there more to see? Or are you seeing what is right? So always investigate. So when we look at our healthcare related incidents and our investigations that we do in our RCAs or our HEAPs or even coronial inquests, there is often that common thread to these events. So there's often situation bias. We're expecting to see one thing when we've actually got another. Misinterpretation of the information at hand, or failure to see and act on the information that's actually in front of us. So it's really important to consider if there is more going on. Are we seeing everything? So the key points from today. So remembering our Q SOFA or our HAT, so our hypotension, altered mental status, and tachypneic as our quick bedside tool for the recognition of sepsis. Remembering our sepsis 6 for our rapid response. So we want to incorporate that patient stabilization. So ensuring that we've got oxygen therapy or maintaining oxygen saturations, remembering that these patients have a higher oxygen consumption rate. We want to make sure that we have adequate and appropriate fluid resuscitation. So doing that to clinical endpoints. So stabilizing our blood pressure and our heart rate, but not creating problems like pulmonary edema or heart failure. Making sure that we've got adequate source control, so performing blood cultures and a septic screen, commencing IV antibiotics that are appropriate. And if you click on those links to those sepsis pathways, you'll see that there's also recommendations or guidelines for antibiotics that we should be administering. And then finally, our ongoing monitoring, so checking our lactate level and urine output. So I don't personally know any of the clinicians or the family members that were involved in this case, but as a nurse, I definitely empathise with the distress that they would have all felt during this case and during the investigations. So I hope that by us all taking the time to go through the case today, that it reminds us of that importance of asking, could it be sepsis? So patients that are at risk of infection or with a known infection demonstrating those clinical signs of deterioration have got a high mortality rate when sepsis isn't identified early or managed correctly. Today, we've had the opportunity to reflect on the problems of sepsis and the important role that we play in the recognition and management. So as clinicians working in Australia, we now have access to a number of sepsis-related resources, and we should all be trying to utilise those in our workplace. So I'd like to thank you all for participating in the webinar today. If you'd like to continue to learn some more around sepsis and clinical deterioration, there's a couple of courses there that you can click on and register to increase your learning. Look out for some more. You'll receive a link to this webinar so that you can rewatch any of the points that you'd like to rewatch. And we'll be doing a follow-up e-learning package as well on sepsis. The coroner's case that we did use has been put into the chat box, so you can read through that if you're wanting to have some more details as well. So once you've completed the post-webinar evaluation, you'll be taken to or you can access your CPD certificate. And I'll just stop sharing my screen there now so we can, if there's any questions there, Ken, you want to go through those?
Sure, thanks Susie, that was great. And I'm sure everyone will Join me in thanking Susie for her excellent presentation and all of the hard work that she's put into preparing it and delivering the actual webinar. So well done. Now, with the questions, there was a few people asking about the paracetamol and the evidence for not using it and in what circumstances. So I thought I'd hand that over to you, Susie.
Yeah, so there's always a lot of debate around paracetamol. It certainly is used. There's a lot of research that has been published, and I can send those out. We'll put that up on the webpage so that you can read them. But essentially, the evidence for administering paracetamol for reducing fevers isn't strong. As I said earlier, it does only reduce it by a small fraction. And it can often mask the symptoms. So this is really where the harm of paracetamol can occur, because we're masking symptoms. So things like the elevation in temperature or the heart rates. And so then we're thinking our patients are more stable than what they actually are. So we're missing those signs of sepsis. So that's one of the key areas of why we shouldn't be administering it. The other side of the coin is that there is a body of research that actually supports the benefits of having a fever. So fever helping us to fight the infection. And so by reducing the fever, we're actually reducing our body's ability to fight infection. So they're sort of the main evidences, but I'll post some of those links to the research that's out there.
Great. And then there were quite a few people who were concerned about the length of time taken between presentation and administration of antibiotics. And we know that in the sepsis guidelines that if we can initiate the antibiotic therapy for either the supposed organism that we might suspect, and sometimes it's because of the clinical presentation or what might be present in the community, then that can be initiated within the first hour. The mortality rate decreases quite significantly, but for every 1 hour after that, the delay results in an increase in mortality of about 6.8%, which is a pretty scary number if you look at 6 to sort of 7 hours later. I'm surprised that she didn't deteriorate further during that time.
Yeah, I mean, given particularly how deconditioned she was as well, I think the fact that there was a delay really with her deterioration, the fact that we gave the antibiotics through the PEG, which, you know, was essentially the source of infection, is also a problem. So we do really want to be timely with the administration of antibiotics, making sure that we're getting it in. So as soon as we're taking blood cultures, antibiotics should actually be ready to go straight away. So we don't want to have those delays.
Yes, and then once the causative organism was identified, the antibiotic therapy, which would be broad in nature, would be de-escalated for the specific antibiotic required for that microorganism.
Yeah, that's right. And I mean, part of the antibiotic prescribing regime, so it will identify what the most sort of a broad spectrum, if you're not sure of the organism, if you think you've got a gut sepsis, what antibiotics. So those prescribing regimes are really quite helpful for knowing which antibiotics should be given. And then every 24 hours, we should be reviewing just to make sure that we are administering the right antibiotics or to see if we need to make any changes based on results that have come through.
Yep. So I think with the antibiotics, a couple of people have said, you know, do you start them before the bloods? It's important to take them to take the swabs before you initiate the antibiotic therapy, because it can actually skew the results of the culture and sensitivity. And a few people are saying about central lines, and yes, I agree. If the patient had the ability to have a central line put in, and that depends on the clinicians at the presenting hospital.
Yeah. And just a point there around your septic screens, if you've got patients who have got a CVAD that has been in for longer than 24 hours, you must take a blood culture from that central line, but you also must take a peripheral sample. So that's really important that we do both the central venous access device sample and a peripheral sample for patients that have got a CVAD in place.
Yes, because it could be that the infections are arising in the central line itself.
And for that student nurse who says that you're being frowned upon for taking respiratory rate, just keep doing it. It is the right thing to do. You cannot guesstimate a respiratory rate. And I can't emphasize more how important it is to actually do an accurate respiratory rate. It is always elevated in deterioration. I see it time and time again. So it's really important that you're doing that accurately. So stay strong. Tell people you're doing the right thing.
Yes, correct. I totally agree. Well, we're actually over time for the webinar. I know there's been a lot of interest and a lot of other questions there, particularly in terms of, how far the patient had to be transferred and things like that. And as Susie said, in regional areas particularly, it's not the same as in a metropolitan area, being able to just call up the ambulance service and getting them to come and retrieve the patient in a timely manner. It can take hours to mobilise our medical retrieval services, and I've done quite a few transfers with RFDS, so I'm aware of what goes in with the logistics of that. So I'd like to thank each and every one of you who've participated in the webinar. Hope you've found it enjoyable and usable information. I'd like to thank the background team who've been working away, so Greg, Abby and Angie for their support. And most of all, I'd like to thank Susie for her excellent presentation and the information that's been imparted. And we hope that this enables you to increase your knowledge and increase your ability to communicate with your peers and colleagues regarding escalation of sepsis care. So thank you all very much, and we look forward to interacting with you in future courses or webinars. Thank you, Susie.
Thanks, everyone. And for those that haven't had their questions answered, I'll go back through and we'll post anything that hasn't been answered if you've got a burning question that we didn't get to.
Great. All right. Thank you, everyone. Bye now.
Thanks, everyone.